So just simple, like CP3, we can do the sternal division or the clavicular division. We're going to go from a short position here into a lengthened position here. So I can go more in a 45-degree angle or a 90-degree angle here, and just continue either active, passive, take your pick. Okay. Usually I go a little more passive on this because it's painful and patients will start to guard. So I find if I do it passively, I get a little bit better results. Part of the pec that a lot of people ignore, because they want to spend the most of the time here, is the division right off the clavicle. So I like to just, even in a lengthened position here in a grade 2, just go straight from the clavicle and literally drop straight down off the clavicle. And then make passes right off the clavicle there. So just digging just inferior to it is a lot of adhesions and fibers that many people miss. Feels pretty good, huh? Yeah. Okay. From this position, I can get the teres major and the other internal rotators. So just like you did in CP6, I know it's tough to see for over there, but I'm just putting my thumb right in his axilla, and I can start it from internal, a shortened position, into external rotation, a lengthened position. Okay? And I can make my passes. The deeper I push, just on the lateral border here is going to be more teres major. Okay? Theoretically, the deeper I get and the deeper I push, it's said that you can get to the subscapularis. I've had conversations with orthopedic surgeons that do surgeries on shoulders, and when you say you can get the subscapularis, they laugh and say, no, you can't. So, debatable whether you're actually on the teres major the whole time, or if you're actually touching the subscapularis. Either way, both are internal rotators, and both are tight. So, you can debate all day what you're actually reaching, but the point is, you're increasing more external rotation by working the tight internal rotators. Okay? From this position, I might choose to do just a simple bicep. Okay? And when I work the bicep, I make sure that I go all the way up. I follow the bicep muscle, but I actually follow the bicep tendon all the way up until it disappears under the acromion. So someone that has a proximal biceps tendonitis, I can work the belly like this all day, and it's not going to do them any good. Okay? I really need to follow the biceps all the way up to the acromion. You'll find a lot of adhesions in the proximal 3-4 inches of the bicep tendon. Okay? And again, you want to watch your pressure. It doesn't do me any good to really dig in here and have him flinching and squirming all over the place. Okay? I'll vary my pressure a little bit so I can get good, solid passes on a relaxed tendon. That's what's going to help disperse some of that inflammation. Okay? From this position, I can put his arm across and even have him hold that. What does that look like to you? Posterior capsule stretch, right? Or posterior delt stretch. So from this position, he's actually helping me stretch his posterior delt and posterior capsule. Remember I told you last week the posterior capsule is generally right underneath the posterior deltoid? Okay, so if I want to add length to that, I simply have him do this stretch, and I make passes here over posterior deltoid. Okay, so I'll make passes down here, okay, through here. I could actually follow it down and get a little bit of the rotator cuff here and get some of those adhesions in the infraspinatus in here too, okay? I could also do, in this position, I could hit his proximal tricep. So again, triceps is a muscle where 85% of the people work on the tricep will focus on this part here. Well, the tricep goes all the way to here, right? So that proximal 4 inches of tricep generally is ignored and can have a lot of adhesions and a lot of tension in it that can limit range of motion, right? So if my flexion is limited, the proximal tricep can play a large role in that, right? I'd put that right along the same lines as the teres major, in limiting flexion, okay? So I'll put him into this position, and I'll work some of that too. And again, be creative. I can do it active, passive, I can do it passive, I can do it active. So what would be short? This would be a shortened position, right? And this would be lengthened. So I can go something like this. Okay? Make sense? All right, why don't you go ahead and face that way. On your side. Okay, so in a sideline position, the only way really, the most effective way that I've seen or that I do to get the serratus anterior is from a sideline position. And everybody here would agree that the serratus anterior plays a large role in scapulothoracic movement, right? And shoulder pathology. So, just like CP3, I think we learned this in there, I'm going to basically, again, I'm concentrating on protraction, retraction, okay? So serratus anterior shortened in protracted position, lengthened in a retracted position, right? So what am I going to have him do? Protraction to retraction, okay? So I'm going to start protraction here. I'm going to have him bring his arm back. So this is almost the opposite of the other one I was doing, right? Because I'm starting from here and going to here. So I'll go from here to here, and I can do this passively like this, and I'm making passes just under here. This is where the serratus lives, okay? And I'm following the thoracic cage all the way around until I try to get as close to the medial border as possible. Obviously I can't reach it, but in my head that's where I'm going, okay? So I can do it passively, or I can treat him how to do it, teach him how to do it, and I can do a thumb. I usually do a thumb with a reinforced contact on top of it, so I can really push. And then at the end, I can get a stretch. Okay? So go to that. Okay? For females, I find the easiest way to do it for females is I have them in a gown. Okay? And I'll stand actually on the opposite side. Okay? I put the gown so they'll be in their shoulder. They either have it over their shoulder or it's tucked in with the shoulder exposed. Okay? And I lay the gown right here along the line here. And I'll usually have this hand protect, and then I'm going to do my same thumb contact, but I'm going to reach from this back side. Okay? So I'm going to have my thumb right here. So I can still do the same move, just not in a compromising position. Okay? Really important in muscle to address. I could do some deltoid work here, pretty simply, passively or actively. You can get the anterior deltoid in here. Okay? You can get the posterior deltoid, but I like doing the posterior deltoid supine a little bit better. Okay? To get that greater tubercle, to really get some length on it, I'll put the patient behind here. So I'm trying to get the supraspinatus in a lengthened position, right? So I'm right here, and I could usually find it right off the acromion. And this is a situation where I'll work towards the insertion. Okay? So if I have tendinitis in that supraspinatus tendon, last thing I want to do is try to pull it away. Okay? So in theory, I'm working towards. Okay? Let's go face down. Okay, so a couple more for the scapular stabilizers. This would be more just the grade 2. Okay, so I'm getting in a lengthened position.
There's paper underneath the table.
If I was considered my patient, I might put that on. Okay, so in this position, I might have the patient's arm behind their back. See how that opens up the rhomboid here? Okay, so I'll get the patient in this position, and I'll pull the shoulder down, so I'm getting maximal length to the rhomboid, and I'll just do grade 2, working up. Sometimes I'll get my thumb, I'll really dig into this medial border in here. There's a lot of adhesions in there. Okay, for lower trap, same thing. I'll put some length in it, and I'll have them go over his head, and I'll work this way, working down the lower trap. Okay? If I want to do some of this actively or with motion, I would have him simply go from here to his hand overhead. So I can work the lower trap as put length into it. Okay? In this position with that same type of move, starting from here and going up, this would be a grade 4 mobilization or soft tissue mobilization for the lat. Okay? So I'm going to stand on this side, opposite side. I'm going to get my contact on the lat. Okay, the lat obviously is here, but again, most people work this area of the lat and don't get this one up in here, as high up in the axle as you can get to. Okay, remember it comes up and runs around to the front and attaches on the front. So I'm going to try to get as high up into here as I can. Okay, so I'm going to have them start in a short position, which is extension, adduction. Okay, and I'm going to come up over his head. Okay, so I'll get my contact here, and sometimes I'll have a double hand contact, have them start down, and then go up. And all I'm doing is leaning back. Okay, if I had lotion, this would be much more helpful. But.
Like skin burn?
Yeah. Okay, but that's a really effective way with motion to open it up. So if your patient complains that, well, I can't get my hand over my head in abduction, what structures here am I looking at? The lat, teres major, maybe a little bit of pec, triceps. Okay, so you can kind of figure it out with what your patient's complaining of, what structures might be most effective. If they're saying I can't get my hand behind my back, what structures am I looking at here? Probably external rotators, right? Posterior delt, infraspinatus, teres minor, that's going to be more the area I'm focusing on too. Okay? So you got to kind of think of, when I do these types of motions, okay, what structures are coming taut that I can release. Okay? That's pretty much it.